Hello, you're listening to Health Professional Radio. I'm your host, Neal Howard. Thank you so much for joining us today. Every one of us is going to face the end of life. It's something that we live with each and every day. Our guest in studio today is versed in end-of-life care direction and preparation. Dr. Kevin Haselhorst is an ER doctor practicing in Phoenix and the author of Wishes to Die For, an introspective guide to advanced care planning, and especially as it focuses on the ER. How are you doing today, Kevin?
I'm doing well, Mr. Howard.
You know, as an ER doctor, I'm sure you know that many of us have that experience with the ER, but when it comes to, the fast-paced day-to-day things that go on in the ER from what we're told, where does the time come in to talk about the end of life? Because not all situations in the ER end up as end-of-life situations.
That's very true. But, there are breaking moments in any conversation where you stop, the wheels of time stop, and you have to take a moment and you have to engage a person in a much deeper level than say a broken arm or a cut or something like that. And because it's, you seek out your priorities or whatever. And I prioritize people who are dealing with end stage disease as something that I'm connected to. Some people connect with little children. I connect with older adults, particularly struggling with end of life concerns, and particularly their caregivers who are engaged in that same conversation and are at wit's end trying to figure out what to do.
Now, we hear a lot about advanced care directives, having a living will and some type of preparation just in case something happens, something in place, or we should have something in place with directions for those of us that we're going to leave behind that are considering these issues. What role do these advanced care directives play in the ER?
I believe they play very little role because most of the time we act before we're able to think. So to be able to find the advanced care directive as to what the person may or may not want, given their situation, some of it is understood automatically. If you're 45 years old and you collapse, you have a heart attack, you're going to get CPR. I don't care what your advanced care directive says. It doesn't apply in that moment. So there's a fine line where it actually takes hold, and mostly regarding persons who are from perhaps a nursing home or elderly population who have DNRs that prefer not to be resuscitated. But ideally, we've known that it's already communicated ahead of time. So even having the advanced care directive has already been sort of attached to them when they came to the emergency room. But I think there's very little value for them in the heat of the moment. I think they're more after the fact when you're left in a persistent vegetative state as to how much kidney dialysis do you want to have if you're in a coma.
So advanced care directives, they're kind of specific, if I'm understanding them correctly, whereas a Universal Healthcare Directive is more general and there's more wiggle room. Is that the correct statement, or do I need to be educated?
I think the Universal Healthcare Directive gives a whole template to the notion of how we live the circle of life. There's a time to live, there's a time to survive, and then there's a time to die. And infused in that sense is this idea of faith, hope, and love. That you have this sense of when faith really serves you in the beginning of life, faith doesn't serve you at the end of life, love serves you primarily. And putting those in a context in the diagram in the book gives a whole clear message about, when it's time to live, you're preventing illness. When you're in end-stage disease, you're being very conservative in your treatment because you know that being aggressive doesn't make sense to put somebody with end-stage disease in the intensive care unit. We all see the mistakes that go wrong when we try to do too much and we haven't really understood that there's an appropriate care given to each part of our life, and that it's not appropriate for people to die in the intensive care unit when they're struggling with terminal cancer. That there's something misguided about that, and part of it is our own confusion and our own dis-ease with the whole aspect of letting somebody go. But clearly a time to die is a time to let people go.
Now, the title Wishes to Die For implies what should your wishes be, or how should your wishes be considered when you die?
Well, the context of the book is written for people in their middle age to have a sense of their priorities and values. And I really want people in the prime of their life to take a look inside and see what's most important to them. Is it family? Is it finances? Is it your spirituality? Is it personal responsibility? Is it personal freedom? What resonates most with you? Because when that's taken away from you, you get a chance, you are allowed to die. You don't have to continue to live indefinitely when your quality of life ends. But we throw out these general words, but until you label it, you don't know when your quality of life ends. If you haven't labeled your quality of life as being the ability to go to Starbucks, or give me liberty or give me death. They're very clear statements that resonate with people and it should empower people to say, yes, if I don't have this, then it's time for me then I'm ready to die. Or if I died at this moment, I would be the happiest person alive.
So the book is more about preparing yourself mentally, spiritually, and I guess rationally for the inevitable.
Yeah, again, it goes back to I see the Advance Care Directive as a spiritual document and not so much as a medical legal document. Because if we're really talking about what matters to people, our spirit, what we're connected to spiritually matters to us more than what the physical world leaves us with.
Let's talk about your book and the feedback that you've received from others in the medical community, other specialists, other ER doctors and nurses, how they've reacted to the book.
I become the advisor. If I get a lot of positive support from nursing and from other physicians who say, how should I handle this, or what would you have done in this situation? And I think I'm giving them permission to pull back from some of the standard of care of how we just cookbook everybody in terms of how we treat people, and taking a step back and saying, is this how we would want to be treated? And making more sense and creating less fear around the legal implications of not doing things at the end of life. If you have an open communication with family, you don't have to worry about the legal repercussions. There's nothing wrong about people dying, and yet we still have that fear that if the person died, we did something wrong.
You've been listening to Health Professional Radio. I'm your host, Neal Howard, talking with Dr. Kevin Haselhorst, an ER doctor who's also the author of Wishes to Die For, which is an introspective guide to advanced care planning from a spiritual, mental, and relationship point of view, not so much as a legal document or talking about financial planning. It's been great having you here with us today, Kevin.
Thanks, Neal.
Transcripts and audio of this program are available at healthprofessionalradio.com.au and also at hpr.fm, and you can subscribe to our podcast on iTunes.